Okay, so this is a different topic totally. It's the cardiodynamics. So when the heart muscles contract, blood moves, there's pressure changes, and the next 14 or 15 slides is about the cardiodynamics. To understand cardiodynamics, you have to know end-diastolic volume. What does it mean? It means that when the ventricles are relaxed, totally relaxed, the ventricle is full of blood. So it has the maximum amount of blood. That's the maximum amount. That's called end-diastolic volume. All four valves are closed. The ventricles are relaxed. End-systolic volume is what after the ventricles contract, blood is ejected, then the semilunar valves close. The amount of volume that stays in the ventricle, that is the after systole, at the end of systole, after the blood is ejected. The amount that stays in the ventricle, that is called end-systolic volume. The stroke volume is the amount of blood that is ejected in each contraction. So the formula is end-diastolic volume minus end-systolic volume. Ejection fraction is the percentage of the blood that is ejected. So the ventricle is full of blood, a percentage of that is ejected. Usually the normal person is between 50 to 65. If a person has less than 50, it's the early stages of heart failure. And if it is like below 40, then it's more severe. Below 30 is very, very severe. So based on that, in the hospitals, they usually measure that ejection fraction. And based on that, they can change the dosage of the medications. So what is the cardiac output? The amount of blood that is pumped out from the ventricle in 1 minute. So left ventricle, because it goes to aorta, and that's the systemic blood that's more important. The same amount of blood, of course, goes to the lungs, but most commonly it is measured in the left ventricle. So it is in 1 minute. The formula is the heart rate multiplied by stroke volume. So cardiac output is measured in milliliter per minute. Heart rate is beat per minute, which is normally is from how much to how much? Yeah, 60 to 100, right? And stroke volume, which is milliliter per beat. So stroke volume is around 70 to 80 milliliter per beat. Then you measure that. So normal cardiac output is between 5 to 6 liters. 5 to 6 liters. And again, it varies from person to person. So factors that are affecting the cardiac output. So look at this formula, the same formula that we had in the previous slide. So heart rate multiplied by stroke volume. What factors are affecting the heart rate? One is the autonomic nervous system, which is the sympathetic and parasympathetic system, right? And the second one is the hormones. These are the, if you see any changes in these, you will have a change in the heart rate. So normally, if the heart rate is between 60 to 100, that's good. If you have increasing heart rate a lot, you will not have enough time for the ventricles to fill. And if you slow it too much, then not enough blood is pumped out. So the normal is this why to keep the cardiac output between 60 to 100. And the stroke volume, which is the end-diastolic volume minus end-systolic volume. So we will break down each of these ones and look at the factors that are affecting the heart rate, stroke volume, and eventually in the cardiac output. So then I'll come back to this formula. First, about the heart rate, okay? So heart is supplied by cardiac plexus. Cardiac plexus is a bunch of nerves surrounding the heart. Part of it is sympathetic system. The other part is parasympathetic system. So the sympathetic system is coming from medulla oblongata. There is two centers in medulla. One is cardioaccelerory center, which is more lateral, and they're sending signals to the lateral horn of the spinal cord. From there, it goes to the ventral root. It goes through the spinal nerve. Then it goes through the white ramus of rami communicantes. Okay, these are all preganglionic, which means it is myelinated, and synapses here. And this is the sympathetic chain ganglia that it should be on both sides. So the sympathetic chain ganglia, there's 3 cervical ones that are receiving innervation from the thoracic area. So the T1 to T4 are supplying cervical, but also supplying T1 to T4 sympathetic chain ganglia. So here is the preganglionic, right? And then the synapses here, and this is called the splagnic nerve, and this is the postganglionic fiber. It means it's unmyelinated, so the conduction is slower. It goes to the heart, and this is supplying the conducting system of the heart, and that will changes the heart rate. So this is one. Because it's acceleratory center, which means what? Heart rate should increase with a sympathetic system. The other one is cardioinhibitory center, and from there, it's more medial in medulla. From there, it goes to the vagus nucleus, and the vagus nucleus also located in the medulla oblongata, and that is going down through the vagus nerve. As you know, vagus nerve is the longest cranial nerve, so outside of the cranium, it's the longest one. And that goes also to the heart, supplying the conductive system, and that will slow the heart rate. So autonomic nervous system, in summary, sympathetic system increase, parasympathetic system decrease. Where are they coming from? From the cardiac centers and medulla oblongata. So how they respond? How the centers respond? Respond to some differences. Okay, so these are called cardiac reflexes. If there's changes happening in the blood pressure or in the chemistry of the blood, then they respond. So you have baroreceptors there. Baroreceptors are in the carotid artery and in the aorta. They respond to what? Baroreceptors, they respond to pressure. So if the pressure decreases, the signals are sent and says, okay, not enough pressure, and the heart rate should increase, or heart contractility. We talk about that later. Also, the chemoreceptors are there, and this is responding to the oxygen, carbon dioxide, and blood pH. So for example, if you have a lot of carbon dioxide, the pH is low, it means not enough oxygen, and you have to do something about it. One of the things is that you have to increase heart rate, so carry oxygen more to the tissue. So any changes in these two then activates one of those centers, and then the heart rate will change. Normally, for homeostasis, you need something is called autonomic tone, which means the balance of the sympathetic and parasympathetic system, the balance of the two. So the balance of the two is based on the two different neurotransmitters. One is the acetylcholine. Does anybody remember where is acetylcholine coming from? Which system? That is the parasympathetic system. And norepinephrine is coming from sympathetic nervous system, right? So the balance of the two, then that will create the autonomic tone, and the heart rate will change based on that. So the conductive system, as you know, that this is continuously sending signals, but it's influenced by the autonomic nervous system. So not everybody has exactly the same rate, because everybody's metabolism is different, activity is different. So the effect on the SA node. The SA node, remember, is part of the conductive system, so it's a pacemaker cell. And this is less negative than the cardiac cell. So the cardiac cell, the cardiomyocyte, if it is in the ventricle, it's negative 90. If it's in atria, it's negative 80. But in the SA node, it is negative 60. So it's less negative, okay? And as I said before, you know what happens here? That is a spontaneous depolarization, which means that sodiums gradually enter the cell. When the sodium gradually enters the cell, that's called depolarization, making the cell membrane less negative or more positive. So bringing it toward the zero or closer to the threshold. Once it passes the threshold, then you can get an action potential. You have to have this threshold. So this is the all or none phenomenon for the action potential. You have to pass the threshold. You can always get a depolarization, but if it does not pass the threshold, you cannot get an action potential, which means the signal cannot be transmitted. So based on two factors, one is that this may be more negative or this may be less negative. So the resting membrane potential, this is one. The second thing is how fast this can be depolarized, how many sodium ions can enter the cell. The faster they enter the cell, it will depolarize faster. It passes the threshold, you can get an action potential. So now let's look at that. You have the sympathetic and parasympathetic system. So in the sympathetic system, which is the fight and flight system, you know, when you have an activity or in a fear or you're escaping from any danger, that is the active one. And what happens here, the resting membrane potential decreases. See, it was -60, now it could be -50. So it's decreased. So what is happening here? Now it's closer to the threshold. So if you have less time for the depolarization, for the spontaneous depolarization to reach the threshold, less time. So now you can get an action potential faster. This is why with the sympathetic system that is releasing norepinephrine, the heart rate increase. See, this thing that you see is one beat to another beat, and this is how you can calculate it in 1 minute. So because it is the resting membrane potential gets closer to the threshold, takes less time. But in the parasympathetic system, what happens here? Look at it here. It can be -65, -70, depending how strong the signals are. So now it is going farther away from the threshold. If it is going farther away, it takes a lot longer for the spontaneous depolarization to reach the threshold, right? And from there, then once it passes the threshold, you can get an action potential. This is why the distance between each heartbeat is a lot longer. So this hyperpolarization, what is hyperpolarization? So this was the resting membrane potential. When it becomes more negative, that's called hyperpolarization. And in this case, it is less negative, so this one is depolarization. So another factor that is affecting the heart rate is called the atrial reflex or vein bridge reflex. What happens here when blood comes to the left atria, then that blood has to go to the, to the right atrium, that blood has to go to the right ventricle. So if you're doing any kind of physical activity, the muscles are active, more blood coming from your lower limbs or from the other part of the muscles and upper limbs, that will go to the right atrium. So more blood will go there. If more blood goes there in the right atrium, that blood has to go to the right ventricle. How it can go there? To increase the rate of the heart, and that will cause activation of the sympathetic system, the heart rate increase. So anytime you are doing any kind of physical activity, more blood goes to the right atrium. That's why your sympathetic system is increased. Why is it increased? Because there's more demand for it. So one was the nervous system, right? The second was the return of the blood to the right atrium. The third factor is the hormone. So you have different types of hormones. One is epinephrine. The other one is norepinephrine. See, this name is familiar. This in the nervous system, this is a neurotransmitter, right? But this can also be released from the adrenal medulla. From adrenal medulla, that is, fibers are coming directly from hypothalamus. Fibers are coming directly from hypothalamus and stimulating adrenal medulla. Then the two hormones are released here. In this case, this is not a neurotransmitter. Why? Because this goes directly to blood, so that cannot be a neurotransmitter. And the thyroid hormone is also another one that it can, once you have more thyroid hormone is increasing metabolism. To increase metabolism, you need more oxygen, and for that, the heart has to pump hard. So that's the reason its heart rate is increased. And people who have arrhythmias, they usually check their thyroid hormone as well, because some people with hyperthyroidism, they can actually getting cardiac arrhythmias. So if you fix that, you're fixing the abnormal heart rhythm. So then is the factors that these 3 slides or 4 slides were about the heart rate, and now this is about the stroke volume. So stroke volume, the formula is end-diastolic volume minus end-systolic volume, right? So let's talk about the end-diastolic volume first, and then I will talk about end-systolic volume. So end-diastolic volume is, once again, is the amount of blood that is at the end of diastole. It's full, the ventricle is full, all the valves are closed. Depends on 2 factors. One is the filling time. The filling time is related to heart rate. So if you're increasing heart rate, what will happen? You have less time to fill the heart. The other one is the venous return, and this can be about the physical activity, right? So when you're doing more physical activity, the muscles are contracting, more blood will come to the heart. If you're resting, less blood will go there. Also depends on the amount of hydration you have. For example, you're drinking more water, you have enough blood volume, so you're good. If you're dehydrated, not enough will go there, not enough blood will go there. Another factor is the sympathetic system. Once the sympathetic system is activated, it will contract the veins, and then more blood will go to the heart. So there is a relationship between the preload and end-diastolic volume. So when you have more blood in the ventricles, then that will increase the size of the ventricle. If it increases the size of the ventricle, it will stretch the ventricle. If it stretches the ventricle, that will cause increased tension, and that will cause increased cardiac contractility. So if you have more end-diastolic volume, it means the preload is increased. Preload is increased because more blood will cause more tension. The ventricles are more dilated. So at rest, end-diastolic volume is low. Why end-diastolic volume is low? Because less blood goes to the ventricle. If less blood goes to the ventricle is not stretched. If the ventricle is not stretched, it cannot contract as much. If it doesn't contract as much, stroke volume is low. Stroke volume is the amount of blood that's ejected. So it's not, if the contraction is not strong, so not enough blood is ejected. Why? Because you don't need it, you are at rest. But when you're doing activities, okay, or in a fight and flight situation, more blood is coming to the right ventricle, okay, and from right to the left ventricle, through the, going all the way to the pulmonary arteries and coming back, and all those things. But end-diastolic volume is increased because more blood is going to the ventricles, right? Now the myocardium is stretched here. If the myocardium is stretched, you have an increase in the contraction. Increase in contraction. This is chapter 10 for NP1. So if you're stretching the myosin, the actins are further away from myosins, and then you have more space, and then they can have a stronger contract. But if you're too far away, then not much is happening. So in this case, you have to stretch it enough to have enough force. So if your myocardium is stretched enough, then it can increase contraction. If the contraction is increased, the stroke volume will increase, and this has a direct relationship. So more blood goes to the tissue, and you have, deal with the increase in exercise demand. So this is the relationship between, when the muscle is stretched and the contractility. If the muscle is stretched, the muscle can contract stronger. That's called the Frank-Starling principle. And how the muscle is stretched? When you have more volume in the blood, which is the end-diastolic volume. But the heart cannot stretch too much because there is 3 different reasons for it. One is that you have elastic fibers and also the collagen fibers between the cardiac myocytes, in between. So that's why it cannot stretch too much. The collagen fibers prevent stretching it too much. The second one is called the cardiac skeleton, and this is the area this is the fibrous tissue that is between the valves and also between the atria, around the valves, between the atria. That is the cardiac skeleton. And the third one is the pericardial sac, which is made of dense irregular connective tissue. So that doesn't matter how the heart distends, the pericardium cannot distend too much. And if you have fluid in the pericardium, that will cause a problem with distension or diastole of the heart. And some people have that with pericarditis. You have fluid in their pericardium, the heart cannot expand. So that will affect the stroke volume. So now is the end-systolic. So we talked about end-diastolic, right? So now is the end-systolic volume. So in the end-systolic volume is the amount of blood that remains after the left ventricle contracts. The amount of blood that remains in the left ventricle. 3 factors are affecting the end-systolic volume. One is called the preload. The preload was the amount of volume that was coming in the right ventricle. And that was related to what? One was heart rate, the other one was the venous return. Those 2 factors were affecting the, the end-diastolic volume, and the amount of blood on the right side will be the same amount of blood on the left side. So that is one. Second thing is the cardiac contractility. So if the muscles are stretched enough, that can produce enough force. But also this depends on the autonomic nervous system, because the sympathetic and parasympathetic is also affecting the contractility of the heart. The third one is about the blood vessels. The hearts are connected. So on the right side, you have the pulmonary artery. On the left side, you have aorta. So there is some pressure there. So the amount of contractility that happens on the heart, that will cause a pressure. And that pressure should overcome. That pressure in the right or left ventricle should overcome those blood vessels. If it does not, then the semilunar valves cannot open. You know that the pressure is always a gradient, so going from the high to low, so it should be higher than the ventricle should produce higher pressure. So from the ventricle can open the semilunar valves, and then the blood can eject it to either pulmonary artery on the right side or aorta on the left side. So that should overcome. But there is a pressure there, and there is a resistance in the pulmonary artery and the aorta, and that is called the afterload. So the heart should have produced enough tension that can overcome that pressure. Factors that are affecting contractility, one is the autonomic nervous system and the other is hormones, the same thing that we had in the heart rate, similar factors. So you have a sympathetic system that is releasing norepinephrine. So this is one source for the contractility. The other source is the epinephrine and norepinephrine from adrenal medulla. So there's 2 different sources. So this is the nervous system, the autonomic activity, the hormones are this one. So by increasing norepinephrine, that will cause increased contraction of the ventricles. If the ventricles are increased, contraction is increased, stroke volume is increased, ejection fraction is increased, which means what? End-systolic volume will decrease. End-systolic volume will decrease. But if you have the parasympathetic system is there, so that's releasing acetylcholine, and that will decrease cardiac contractility. If the cardiac contractility decrease, ejection fraction decrease, stroke volume decrease, which means end-systolic volume will increase. Ejection fraction decrease, stroke volume decrease, end-systolic volume will increase. And the hormones, so like epinephrine, norepinephrine, and also the thyroxine, which is for the thyroid hormone. So they will increase heart rate. They also increase heart contractility. From autonomic nervous system point of view, the heart is supplied by the beta receptors. Okay, so the sympathetic system has two types of receptors. One is alpha, the other one is beta. So heart is supplied by beta. Alpha is mainly in the blood vessels. So there are some, with manipulation, you can change that. For example, you have medication that can stimulate the sympathetic system. They are called beta agonists. They will increase heart rate. Or you may have medication that actually decrease heart rate, and that is the beta blockers. So this can be used during arrhythmias, sometimes for treatment of hypertension, and also for heart failure. It can also be used. Calcium is important for the muscle contraction. So there's other medication that actually used that can block the release of calcium, and that will be used for treatment of hypertension. That reduces cardiac contractility. Less calcium there, the contractility of the muscle is not strong enough. So less stroke volume, the blood pressure that way also really decrease. Afterload, as I said before, is the the resistance from the aorta, mainly from aorta, but also in pulmonary artery. The pulmonary arteries, resistance a lot lower than aorta. So afterload, we usually talk about the left ventricle and aorta there. So here you have to have enough, contractility to overcome that. And if the contractility is decreased, it cannot overcome the resistance, and that can be a problem. So if the blood pressure increase, which is the pressure in the aorta, so if that increase, then the heart, if you keep the contractility the same, it means what? Stroke volume decrease. If you want to, if the blood pressure increase, what do you have to do? You have to increase also the cardiac contractility to overcome more pressure or more resistance from aorta. And if you don't do that, what will happen there? The heart cannot contract enough. More blood will remain in the left ventricle. More blood remains in the left ventricle, and that causes decrease in stroke volume. So over time, what happens in real life patients, that the left ventricles become thicker and thicker and thicker because there's a lot of resistance in aorta. So the left ventricle is working harder. So the muscles become thicker and thicker and thicker. So for a while, for a few years, it will work. But after a while, those muscles will fail. So this is why hypertension, they call it a silent killer. Why? Because it will eventually cause heart failure. So you want to prevent that. And that reason is because of the afterload. You have to decrease afterload. If you decrease afterload, you will decrease the work of heart, decreasing the muscle contraction in the heart. You don't want your heart to work too hard. So this is the stroke volume, right? So what was the stroke volume? And the diastolic volume minus End-systolic volume. So look at the factors that are affecting end-diastolic volume. So remember, preload are connected to end-diastolic volume. So if you have the increased venous return, end-diastolic volume increase. This is obvious, right? So more blood is coming to the to the right atrium, more blood will go to the right ventricle. So this is, for example, during activity, or when you are at rest, the muscles are not active. Okay, you're not drinking. Okay, the volume is low. A lot of blood is pooling somewhere else in the veins. So less volume goes to the right atrium. From right atrium goes to the right ventricle. So less blood is going there. That's why end-diastolic volume is decreased. Filling time. Okay, if you are increasing the filling time, so you're allowing more time for the right ventricle to fill. So the blood will go to the right ventricle, so you're filling the right ventricle. But again, you don't have to give it too much time, right? So the normal between 60 to 100 per minute. And if you're decreasing, if somebody's heart rate is very fast, and then what happens? The end-diastolic volume also decreases. So this will affect the end-diastolic volume here, which will affect the stroke volume. So stroke volume will decrease, right? In systolic volume, there is three different factors are there. One is that the preload. So we talked about the preload already. So the other one is the contractility. For the contractility, you have the autonomic nervous system and you have the hormone. If you are increasing sympathetic activity, contractility increase. If contractility increase, what will happen? Stroke volume increase, ejection fraction increase, but you will have less blood in the left ventricle. So end-systolic volume will decrease. Parasympathetic is the other way around, right? So if you're decreasing cardiac contractility, stroke volume, ejection fraction decrease, you will have more blood in the left ventricle, right? Same thing with the hormones, epinephrine, norepinephrine, thyroid, glucagon with the less, they all increase cardiac contractility. So they will increase stroke volume, decrease end-systolic volume. And the afterload. So if you're increasing the pressure in the aorta or in the other blood vessels, this is the vasoconstriction. So heart has to work harder, right? If heart has to work harder, then the stroke volume decrease, ejection fraction decrease. It means more blood will stay in the left ventricle. So end-systolic volume will increase because there is more resistance there. But if the blood pressure is low, the heart does not have to work really hard. So ejection fraction increase, stroke volume increase, cardiac contractility is good. So less blood will stay in the left ventricle. So this is all that will affect the stroke volume. Now, our main thing is the cardiac output, because this other part of the cardiac output is the heart rate. So put the whole thing together now. This is the cardiac output. Remember, in the beginning, I showed you this formula. So this again. So you have the heart rate. What are the factors for the heart rate? If you have more blood coming to the right atrium, remember the right atrium distance, that will activate the sympathetic system. That will cause the atrial reflex, which will cause activation of sympathetic system, contraction of the atria, and also increasing heart rate. Hormones like epinephrine, norepinephrine, thyroid, increase heart rate. Venous return. Okay, so when you're doing more activity, more blood is coming. Okay, if more blood is coming, same thing, atrial reflex. So that's increasing heart rate. Another thing is the muscle activity that I was talking about, blood volume. So if you're drinking more venous return, if you do not have enough volume in your blood, if for example the patient has vomiting, diarrhea, severe dehydration, sweating a lot, things like that, blood volume decrease, venous return also decrease. And the changes in the peripheral circulation. What does it mean is that if sympathetic system is activated, it will contract veins. Veins contain 2/3 of blood. Okay, 1/3 is in the arteries, 2/3 and the capillaries, 2/3 is in the veins. So some, it's called venous pooling. So some blood from the veins will shift it and it goes to the right atrium. So it goes back to circulation. So if it is contracted, more blood goes to the right atrium. And if more blood goes to the right atrium, again, the atrial reflex, increasing heart. The heart has to get rid of extra volume. So that's why the heart rate should increase. The stroke volume, you have the end-diastolic volume minus end-systolic volume. For end-diastolic volume, you have the venous return. So more venous return coming, increasing diastolic volume. Filling time, you have more filling time. The heart can fill with more blood. So that's changing in the diastolic volume positively. The end-systolic volume is affected by three things. One is the preload, which is again affected by venous return and filling time, heart rate, by the contractility of the heart, which is the sympathetic and parasympathetic. Sympathetic, remember, is increasing contractility, parasympathetic decreasing. Hormones, mostly, they are increasing contractility. So the more contractility you have, the more stroke volume, more ejection fraction, less end-systolic volume. And the last one is the afterload. If you increase resistance, end-systolic volume also increases. If you're decreasing this, end-systolic volume also decreases. If you're increasing this, stroke volume decreases. If you're decreasing this, stroke volume will increase. Adding these two together, that will affect the cardiac output. And this is where you live from the time you're born until then. This mechanism continues throughout life.